Thanks, Erin, and hello everybody, and welcome to this session. So as Erin just mentioned, it would be really great if you can write your name and your place of work in the chat so that we can all get to know each other and know where we're all based. I'm Catherine. I'm a palliative care specialist. I'm from the UK. I'm currently based in Geneva, and I'm working with MSF to support palliative care. And today we're going to have a session on ethics in palliative care, which is such an important topic. And it's actually often one of the biggest challenges in palliative care is to deal with the ethical dilemmas or the ethical challenges that often arise when caring for patients towards end of life. But before we move on to today's session, we'll just talk through some basic things for using the Zoom platform. So when we use the Zoom platform, if you can keep your video on, it's really nice because we can all see each other. So that's nice. So it feels like we're more together than working through the computer, which these days we get used to doing. But if you're not speaking, please keep your microphone off because otherwise we get some feedback and we can hear noise when the presenters are talking. So cameras on if possible, microphones off unless you're speaking. If you're having any problem with your connection, just turn your video off because usually that's enough to just resolve the internet connection that you may be having. So just close your video if you're having some problem either with the sound or the connection coming through. So it's great to see people still joining. We've got 17 of us on the call already, which is wonderful. And I'll just share who we've got here in the chat. So we've got Lemek, who's a nutritionist from Kenya. Welcome, Lemek. We've got Yvonne, who's an ecology nurse based in Rwanda. And we have Bang. Hello, Bang. We know each other, who is nursing supervisor for MSF in South Sudan. So wonderful to see you again, Bang. So wonderful. So we're getting people joining from different countries, and we're coming together to, with our shared passion, let's say, for palliative care. And it's wonderful to have representation from different settings. We've got Rose as well from Rwanda who's joined us, which is great. Hi, Rose, from the Palliative Care Association of Rwanda. Wonderful. So Erin, is there anything more to share before we get started? Anything from your side?
No, I don't think so. We usually run for about an hour and a half. The second portion is a case, so if you can stay with us. And we did, Catherine, just at the end, want to present a few slides about the workshop that we held in November. So we have a few photos and just a few next steps. So we can do that at the end.
Wonderful. Yeah, so we'll have time for that. That's great. Thanks, Erin. Thanks, Celian, for writing. You're working at the Aga Khan University Hospital in Kenya. So welcome, Celian. Great. And we might have some more people joining. So as Erin just mentioned, this session will be an hour and a half. And the first part of the session will be a presentation on ethics in palliative care, which is given by Esther, who I'll present in a moment. And then we have the MSF team from Homabay, who will be presenting a case. And we'll have time for questions and discussion, both, I think, after the presentation, and then, of course, after the case as well. So we can... Josephine, if you could just mute your microphone. Super, thank you. And after the case, we'll have time for questions and discussion of the case as well. And then over to Erin to share about the recent conference in Kenya. So let's move on. So Esther is our presenter today, and Dr. Esther is head of the Pain and Palliative Care Department at the Kenyatta Hospital in Kenya. And I've heard from Erin is a very wonderful resource for palliative care, and often is supporting many different teams and different people, even beyond her normal reach with palliative care. So it's wonderful to have you with us, Esther. And Esther's been helping out with the ECHO programs for some time now. So she's really an expert in this area and with palliative care in these settings. So without any more delay, over to you, Esther. Thank you very much.
Thank you. I'll start sharing my screen now. I hope you can see it well.
Yeah, looks great.
All right, so I'll take about 20 minutes to talk about ethics in palliative care, especially in the humanitarian setting. There's a lot of things we can discuss about ethics, but I'll try to just give an overview of the common problems we encounter in palliative care. So by the end of the session, participants should be able to define what ethics in palliative care is and to discuss common ethical dilemmas in palliative care in the humanitarian setting. So really it's to equip you with a bit of knowledge and skills to know how to handle the dilemmas that come. So ethics has been defined as a system of moral principles or rules of behavior. It's a way of life or a pattern of conduct and the reason why people choose to act in a certain way. So ethics are defined by professions. You find that in the legal profession, accounting, medical, we have our own different set of ethical principles that we adhere to. So in healthcare, we have 4 ethical principles that guide our interaction with patients. The first 2 often go together because the first principle is beneficence, where we aim to do good. Then maleficence is to do no harm. So all decisions we make about patients are meant to do good. So it's to look at benefit versus risk of the intervention that is being prescribed. Autonomy is the moral right of an individual to choose and follow their own plan of life and action. Therefore, this principle focuses on decision making, that patients have the right to make their own decisions, and we'll look at them as we go on with the presentation. And justice is about fair distribution of social medical resources. So all patients should be treated equally, despite their social status, their culture, the ethnic groups where they come from. They all deserve to be treated fairly, and also there needs to be fair distribution of medical resources across the country, which sometimes is not the case. Now, when we look at the issues that are common in palliative care, so first we have confidentiality. These are the ones I'm going to go through briefly. Decision-making, information giving, then there's withdrawing and withholding treatment, advanced care planning, and some issues that arise when we are doing end-of-life care. Sorry. So we start with confidentiality. So patients have a right for us to keep their information confidential. So any information that the patient shares with you is supposed to be confidential. It's supposed to be a secret that you keep. But sometimes we find that we go ahead and breach this confidentiality. So some of the questions to think about is how and when do we share patient information? Do we even seek consent? So when a patient comes to see us and the patient has been brought by the relatives, do we stop to ask the patient whether they are comfortable to have those relatives with them in the consultation room, or they would like some privacy so that we can see the patient, examine the patient, and discuss issues about the patient before we divulge this information? Then at what point do we involve the family in the care of the patient? Is it at the time when they present to the clinic? Is it later on? And do we actually seek consent from the patient before we start sharing information about their illness? Some information is very sensitive. We get patients who might be suffering from HIV, patients who might be suffering from cancer. The patient might not be comfortable to share information with the family members, because sometimes in our setup, the family member that brings the patient to the hospital is the one who is paying the bill or the one who is financially able. But that does not mean that the patient is actually comfortable sharing their medical history with this person. So it is good to always ask before we start sharing information. And legally speaking, we can only breach confidentiality when, for example, a patient is not sound of mind to make their own decision, when the patient is maybe in a coma unable or is incapacitated in one way or another and not able to make decisions, and also when a court of law demands that they want this medical information. Again, when it comes to decision making, patients have autonomy, or they have the ability and the right to make decisions for themselves about their treatment. So even when we are discussing options, be it palliative care or curative interventions, the patient should be the one making decisions, unless the patient is incapacitated mentally or physically and unable to make decisions. So before you get decisions from relatives that this patient is too sick, we are not going to intervene, and we are giving direction to the relatives, it is important to involve the patient first. Ensure that the patient has capacity or lacks capacity to make the decisions, unless the patient make an informed decision. An informed decision means that you're going to give the patient all the information about their illness, their treatment options, the interventions that exist and your recommendations, and the patient is going to decide for themselves which interventions they would like to pursue. When it comes to sharing information with patients, how much information do we actually give the patient? It is very common in palliative care to interact with patients who have no idea what they are being treated for, what their diagnosis is. Some have even been referred to us that this patient needs palliation, but the patient is not even aware of their diagnosis, leave alone that they need palliative care or what it means. So patients have a right, first, we've talked about privacy and confidentiality, then they have a right to be given information. And this information should not be filtered. We should not decide that this information is too much for the patient and this is what we are going to share. But the patient has a right to know about their diagnosis, their prognosis, the treatment outcomes, and the available treatments within where you are working, your institution or your region, and even beyond your region. The patient has a right to know that I'm suffering from sickle cell. Sickle cell anemia has complications of low blood count. There could be complications of chronic wounds. There could be complications of pain. The treatment, there is this medication that is given to prevent infections. These are the hospitals that have hematologists or the kind of care that the patient needs. We need to give them that information so that they can make an informed decision. Then patients also have a right to seek a second opinion. So when a patient wants to seek another opinion, it is not that you've not treated them properly, but they have a right, because as they are making an informed decision, especially when we are giving palliative care, most of the time the diagnosis is incurable, the disease is chronic, there's going to be a lot of suffering.
Dr. Esther, I think we've lost your sound, unless it's just me.
Yeah, Elsa cannot hear.
Can you hear me now?
Oh yeah, it's good now.
Yeah, that's better. Thank you.
Okay. Sorry, I think my internet is a bit unstable. So the next thing is about withdrawing or withholding treatment. So those two issues, withdrawing treatment means that we stop an intervention that is not benefiting the patient, and withholding treatment means we do not start an intervention that is not going to benefit the patient. So when there is no benefit in carrying on or starting a new intervention, there needs to be a discussion between the healthcare provider and the patient on the way forward. So you need to give this information in a sensitive way, and you need to explain the risk versus benefit of the intervention. So especially when it comes to end of life, sometimes we find that interventions such as antibiotics, fluids, aggressive interventions might not help the patient. Even in some setups, nutrition is withheld. In our setup, culturally, it is very hard to withhold nutrition, but some of the issues we discuss is medications that the patient is on, things like antibiotics, things like fluids. So you need to agree on the way forward, but it's to look at the risk versus the benefit of that intervention. If the interventions the patient is getting are not adding value to their treatment, they need to be withdrawn. If the interventions are not going to add any value, they need to be withheld. So what of the patient's family? Now, sometimes when we get to end of life, remember in palliative care, we are not just taking care of the patient, we are taking care of the patient and the family. So when we get to end of life and we are having discussions about withdrawing or withholding care, again, remember to seek consent from the patient if the patient is in good condition mentally, that the patient is sound of mind, then discuss with their family this intervention so that now they can make a decision on the way forward. So this discussion of withholding, withdrawing care falls in the category of issues that we discuss when we are discussing advanced care planning. So advanced care planning is really about making decisions for end-of-life care or for care, medical care when a patient is incapacitated. So this is a discussion that will typically happen between a healthcare provider, a patient and their family, or significant others or friends, the person that the patient feels needs to be involved in making decisions about their care. So the things that we discuss in advanced care planning, we have life-sustaining therapies. So life-sustaining therapies include mechanical ventilation and care that is given in the intensive care units. And these interventions are meant to prolong life. So things like ionotropic support, mechanical ventilation, dialysis, they fall under that category of life-sustaining therapies, ionotropic support. So sometimes, like in Kenya, in the setup where we practice, we have resource limitation when it comes to life-sustaining therapies. So most of the time, patients who are receiving palliative care do not qualify for the life-sustaining therapies, but it is good to have this discussion because in the private setup, in the government setup and in the humanitarian setup, you might not have access to the life-sustaining therapies, but some patients might be able to afford private care. So sometimes when they go to the private setup, it will be offered to them that as much as someone has advanced cancer, someone has multiple organ failure, they would still want to admit them to ICU for mechanical ventilation and to keep prolonging their life. So it is good sometimes to have these discussions and they're best done before a patient's condition deteriorates. And resuscitation is part of that discussion, that in case someone's heart stops or they stop breathing, should we try to revive them at all costs? So these discussions include, again, withholding or withdrawing treatment, the place of care like ICU, HDU, artificial feeding and hydration. And when we are doing this discussion, it is important to simplify the terminologies so that the patient and the family can understand the difference between life-sustaining therapies and palliative care, and why sometimes palliative care is a better option, because even research has shown these life-sustaining therapies only prolong suffering. They prolong life, yes, but they prolong suffering for the patient and the family. And most of our palliative patients, when they're in end of life, even when we try these interventions, the outcome is still poor. So when we are faced with an ethical issue, it is first very important to try and assess the magnitude of the issue. Then how we frame this discussion so that, because when you have a dilemma, sometimes you don't have a straightforward answer, but it's good to assess what the patient knows and what the patient's values and beliefs are. Then give the patient information about their care or the alternatives that are there for their treatment, discuss their beliefs and choices with their significant others who could be their family members, could be their relatives, could be their neighbors or friends, then record the patient's care choices. So the best way with ethical dilemmas is actually to try and make decisions that actually reflect on the values and beliefs of the patient and match the decisions that the patient would have liked to make in the event that these decisions are not being made by the patient. Now, sometimes it is not very easy, and we sometimes do not have ethical dilemmas, what we do is sometimes to discuss. So you find in some setups, like in our hospital, we have a hospital ethics committee. So these dilemmas are brought to the committee, and the committee discusses and gives recommendations. Sometimes so
Dr. Esther, oh, okay, we've got you again. We just lost you again for a moment.
Stable,
yeah.
I'm saying, yeah, in the event that there's no hospital ethics committee, it's always important to remember that when making decisions on ethical dilemmas is to consider the risk versus benefit to the patient, and always try to make a decision that is beneficial to the patient. Lastly, consider cultural and spiritual issues. What are risks associated with illness, dying, and death for the patient? What is their belief system? And what is their spirituality? What is their meaning? What do they attach the meaning of life, illness, and death? So that even when we are making decisions, they have to reflect what the beliefs and values of the patients are. So in summary, today we have reviewed ethical principles in palliative care, some common ethical dilemmas, and how to handle patients and their families, especially when trying to make informed decisions.
Dr. Esther, is that the end, or have we lost you again, just to make sure we're not cutting you early? Ah, yes, you've stopped sharing. Thank you very much. Thank you, Dr. Esther. That was a very good overview of ethics and the points that we need to consider when caring for patients with palliative care needs. I just want to ask everyone to have a think through Esther's presentation and see if you have any questions or comments. And you can share these either by just raising your hand on the Zoom platform. You'll find the hand button, I think it's under more, and let me just check, where is it? Because I don't find it now. Raising your hand.
It's reactions.
Yes, under reactions,
now.
that's it,
Yeah.
I found it. Under reactions, there's an option to raise your hand. So if you have a question you want to ask out loud, then please do either raise your hand. The other option is you can write your question in the chat. So either option is fine. And Bang, I see you've got your hand raised. Over to you.
Yes. Good afternoon, good evening, and maybe sometime. Yeah, my question is about but sometimes with the patient, they don't want
Bang,
to
sorry to interrupt you. Sorry to interrupt you. The sound is a bit poor. Do you mind to just close your video while you're speaking so we can hear you clearly? Thank you very much. Yeah.
Hello.
I think that's better. Yeah, carry on.
Yeah, of course. I said sometimes it happens that maybe the patient they don't be able to know the diagnosis, and then they fall maybe the parent also push the letters and maybe nothing so that they want to know the status of the patient. So how can help us tonight, or maybe palliative care, because break the word palliative care.
Sorry, Bang, I don't think we're getting you still. I'm so sorry to interrupt you. The voice is very, very muffled. I think it's the internet connection. Could you type in the chat? Super. Yeah, thank you very much. Thanks, Bang. So we'll wait for your question in the chat. We'll just see if there's any more hands raised at the moment. I don't see any at the moment. While we're waiting for Bang's question, can I just ask Dr. Esther, can you say something? Well, there's 2 points that I just wonder if you could say something about. The first is around autonomy, and have you come across and worked in any with any families where the patient themselves doesn't want to make choices, and how do we manage that? So about deferring autonomy to family and your experience of that. And I think the other thing that I think I've forgotten. Let's start with that one, and I'll think through the other point that I wanted to ask in a moment.
All right, so it's a very common scenario in our setup because our culture is family-oriented culture. So decision-making is actually not for the patient, but for the family. So sometimes patients will tell you, I need to consult my brother, I need to consult my husband, I need to consult my family. So in this situation, often we ask the patient to either give us a medical proxy, someone they would defer the decision-making to, someone they trust, or sometimes we actually do organize a family conference with these family members that the patient feels are important in the decision-making, and we discuss with them the issues about the patient and the kind of decisions that we need to be made about their treatment or about their care. Thank you.
Thank you, Dr. Esther. And it's come back to me the other points I wanted to just exchange with you. Yeah. So the other points was really around when we think about ethics and withdrawing and withholding treatment. I just want to ask you about your experience with different patients and families and about the importance of building trust for making these decisions. And I just wonder what your experience is around that and if you could talk to that.
So in practice, I have found it easier to withhold rather than withdraw care, because again, when we try to withdraw care, even if the intervention is futile or it's medical futility, many patients or family members feel that withdrawing an intervention is hastening the death of the patient. So we find it easier. We find it easier to actually have a discussion to withhold that these interventions are not going to help the patient. So let us take this other route of interventions that will actually benefit the patient. We have not been very successful in withdrawing treatment here in Kenya. A lot of the times, once we start an intervention, we have to keep going. I can see Dr. Zippy has raised her hand.
Yes, please.
I'll not have my video and I'm in a place where it's not convenient, but I just want to also just add to, I think what Esther said is actually very important. Withholding is easier than withdrawing because of a lot of things. I think one of the things we need to remember is as we deal with each patient, we have to remember their culture, their beliefs, their religion, all those things play a major role in the final decision. And so I think in this country, autonomy is a very tricky thing because we as a people in Kenya or whatever, maybe I don't know where you're from, there are many things that help us make decisions, things like religion, things like family, things who's the head of the family. So every patient should actually be approached individually. And I think the decision should also involve the family members in what should be happening, because sometimes patient might make the decision and the family will say no. And many times, Esther, you know that we have put drips up just because the family are saying the patient is starving to death and because they want something to be done. I recently had a patient in Nairobi Hospital ICU who had a bleed in the brain and was there for quite some time. Luckily, his wife works for the UN, so they were able to afford the ICU in Nairobi also. So even money is the reason why he was also put in ICU. That's one of the other things. And one morning, the family was called and told that this patient is brain dead. I mean, there are machines that are actually, and after like 2 weeks almost, the machines are the ones that are really keeping him alive. What do you think we should do? And this family said that they gave them the options. The doctors gave them the options, and the family said, "We would like you to withdraw the life-sustaining treatment, and then let whatever happens happens." Within 24 hours, the gentleman had passed on. So there are people who are also realizing fatal treatment is not, we need to get rid of it. But again, like I said, if you're making a decision, you really have to look at who are you dealing with, because you can make a decision and then the family becomes very, very anxious, very distressed, thinking that, we did something wrong. We allowed our patient to die. Maybe if we had continued. So I can't say there's a blanket decision or a blanket whatever. I think it's just every individual, we have to approach them very differently, depending on where they're coming from, themselves, how learned they are, and even learned people will still tell you, do everything that you can. So it's really, I wouldn't say there's really like a solution to most of these things. It's just the way you handle your patients and families. Thank you.
Thank you very much, Dr. Zippy. And I just want to emphasize that and the importance of what you spoke about and the individualized care And while we may know that for certain patients, for example, continuing fluids at end of life is potentially could be more harmful than stopping them, if for the family that's such an important intervention, you actually can do more harm to that family if you push forward with your own ideas without actually thinking about what's right for this patient and this family in this setting. And that's why it's so important to, as Dr. Zippi and Dr. Esther have said, is really to, who is the patient in front of me? What are their values? What are the family values? And then therefore, what is the care plan for this patient and family? And it's very much individualized. Thank you for that. And we've got Bang's question that's come through in the chat now. So Bang says, my question is about patient diagnosis. It happens, some of the patients are refusing their diagnosis to be told to their family members. As a palliative care doctor or nurse, what will you do if the family disturbing you about their relative diagnosis? So this is a patient who, if I've understood correctly, patients who don't want to share their diagnosis with the family, and the family are asking the doctor and nurse for the diagnosis and how to manage that situation. Dr. Esther, do you want to have a go at that one?
Now, in the case where the patient does not want us to give information to the family, because we still need their consent before we can share the information, because the patient autonomy principle says that the patient is the decision maker. So sometimes it's to try and find out why the patient wants to withhold information from their family, especially when they're getting palliative care, because sometimes they need support from the family, or to know how much information the patient would be willing to share with the family. But in cases like that I have encountered in clinical practice, we actually do not share the information unless now the patient becomes incapacitated and we need the relatives to make decisions on their behalf. Then we have to break the confidentiality. But again, there's no straight answer. You have to just handle the situation depending on the magnitude of the situation and the specific patient.
Thanks, Dr. Esther. Bang, I see your hands come up. Do you want to make a comment? Try turning your video off and we'll see if we can hear you. Otherwise, I'll let you know and you can type again.
Okay. Good. That is a good answer. But my other question is like, for example, maybe the patient after the patient is the end of life, like maybe the patient life. So
Bang, I'm so sorry. It's not coming through. It's not coming through. It's really muffled.
Okay.
Can you type again? Sorry for that. While Bang comes back to us with his comments, there's another question here from Lamek, and the question is, can we engage children on ethics issues, on treatment, or we can only engage the family members? Okay, Dr. Esther, Dr. Zippi, do you want to answer on this one?
All right, so according to the law in Kenya, children do not make decisions, and a child is less than 18 years, so parents or legal guardians make decisions on their behalf. But still, that does not mean that we withhold information from them. We seek consent from the parent or legal guardian to also discuss a few issues with the child. But when it comes to ethical issues or decision-making for treatment, it falls on the parents or legal guardians. Dr. Zippi?
Yeah, that's a tricky one because unfortunately our law does not allow children to make decisions, which is really not correct, because a child who is 7, 8 years can actually decide sometimes, but maybe even 10 or 12 can decide what they want. And so sometimes you find that you're telling the family to have the child's leg amputated because of the disease, then they say no, and you've told the child, and the child, maybe you've had a conversation with them and told them this could save your life, and the child says once and the family says no. And if you try to enforce it, they actually take the child away from the hospital. So one of the things I've seen over time happening is that the tumor board or the ethics committee will usually come and meet and have lengthy discussions on how they can go forward with these things. And some people might even take it to court because they want to save this child's life. And I think we don't see much of that, but it's happening now. I think one of the things that is also very important is just to try and find out why why the family would not want something that's positive for the child, because I think a lot of times it's because we don't spend time in discussions, we don't spend time explaining the benefits and maybe the negative effects of anything, and so people are not really able to make informed decisions. Even in this case of a patient refusing to have their diagnosis disclosed to their family members, you have to explain to them why it's also important maybe for them to disclose their family members, because probably the family members are the ones who are paying the bills, the ones who are going to deal with this patient when they go home and they're very sick, they need to understand many things. So sometimes I think it's a lot of, in palliative care, we spend a lot of time in discussions, talking, family conferences, and with really intensive discussions, a lot of times people will change their mind about something. So I think it's really just how we practice over time and how we learn how to communicate with the family and patients. So it's very important.
Maybe if you can allow me also to comment on that.
Yeah, go ahead.
Go ahead. I'm not the convener, but go ahead.
Okay. Now, from what I've realized is that a child, especially those ones who are above 5 years, when they know what you are doing for them, they become very cooperative and very supportive. And I've noticed it in the treatment of children with cancer, and they tend to cooperate and support the process. Okay, in most cases, like in our culture, you realize that when we talk of the issue of diagnosis, you realize that in most cases, the relatives even know about the diagnosis before the patient himself knows. So by the time the patient is telling you not to tell the relatives also is, on the other hand, telling you not to tell the patient about the diagnosis. So sometimes you find yourself in an ethical dilemma. But for the issues of children, there is also assent and consent. The parents can give a consent for treatment to go on, and a child who is above 5 years and is below 17 also can give an assent. And sometimes you find that some children refuse. And especially when you want to withdraw blood or when you want to take samples, they refuse. But when you continue discussing with them and giving them the reasons why such a thing has to happen, why a treatment has to happen, why they will feel pain, but for a short while and things like that, they become a very good support system with the treatment of their relatives. The parents also, they make decisions. Some decisions are harmful, some decisions are bad. Can give an example of recently we had a young man with the Hodgkin's lymphoma, and that boy was 16 years. And just immediately when before we started treatment, the parents decided that the boy has to be taken away because they have other alternative medicine, I think herbal and the rest. And we followed up. The good thing, we even informed the administration. When they tried that one and it did not work, the boy died recently. Then the parents were coming up to say that we did not tell them that if they did not bring the patient for chemotherapy, the boy would die, but it was already too late. So sometimes you realize that what they decide, they're deciding it out of lack of sufficient knowledge or sufficient information or being confused in the middle. So culture also still plays a lot along treatment, and especially in our African setup, and I'm looking at Kenya as an example.
Thank you, Pamela. Thanks for sharing. Erin, do you want to come in there?
Yeah, I think, and I think on this call, we're a community from kind of all over. So I think people will have different experiences. I know from the team in Dadaab, in the refugee camp, I mean, Dr. Esther and the team in Kenya has been supporting them for a while now. But I actually think a lot of the ethical dilemmas that people face, and I don't know how the others in the group from the other countries or other humanitarian settings are, the ethical dilemmas, it's like lack of access to treatment. And it's almost not between the healthcare team and the family. It's just, as a healthcare provider, we actually have like internal dilemmas, even within our team, and we can't offer the treatments maybe we've been trained to know, that's best practice. And I think that is probably for another day, another discussion, because we could probably spend another 45 minutes discussing that. But I know when Annalise and I connect, or when Ali or some of the people that are on the ground, they know, yeah, it's even another conversation, right? Because people that they are taking care of may or may not have access to treatment, and then it is really difficult to know how to have those conversations. We had it with the team in South Sudan who shared the case two times ago, where they had the young child who had a serious illness of leukemia, and then access to treatment just wasn't there. So the ethical dilemma on top of then having limited access, I think it's a real challenge. And I do hope that we as a group can find ways to support one another. Obviously the ethics of whether to do treatment or not, and then also when you don't have access to treatment, how to be able to deliberate amongst your team, to debrief, yeah, it's very tricky and overwhelming, I think. Maybe tricky is not the right word. It's overwhelming.
Thanks, Erin. Thanks for sharing that. We've also got Bang's second question in the chat, but I'm going to ask that we can answer it in the chat, if that's okay, because I'm very aware of time. And we have now a case discussion. So we have Leah, who's working with the MSF team in Homabay in Kenya. Now, Leah is a social worker, and she's going to present a case for us today. And Leah, I just want to ask, before you present your case, if you could just share with us a little bit about the setting that you work, whether it's inpatient, whether it's home visits. Just share us a bit about the type of patients that you see, just so that we have a bit of an insight into the place that you work, and then we look forward to hearing about the case. Thank you very much for preparing it and your efforts for putting it together. So I'm handing over to you, Leah. Thank you.
Hello, we just wanted to know who will be unmuting during the session. Is it Anita?
Yeah, it's Anita.
Okay.
Good afternoon.
Good, welcome.
Okay, good afternoon. Thanks for the platform. This is Susan Adingo, the presenter. And on the background, we are a team of palliative care in Homabay, MSF MH. So in Homabay, we offer both inpatient palliative care. We also offer home-based palliative care services and also outpatient palliative care services. So we'll go straight to the sharing the cases. The name Susan Adingo, Leah, Anita, Oriema, and we have others as well. Go to the slide. So the next slide, please.
It's now on the patient details. Can you see it?
No, we are not seeing the patient details.
Okay, Erin, I'm seeing the screen patient details. So yeah, if you try sharing again, that would be great. Thanks, Erin. Okay, team in Homabay, Anita, do you see the screen now, patient details?
No, not yet. We are not able to see.
Okay, perhaps what we can do, if you open the presentation yourself on your own computer and open to patient details, and you can let us know when it's time to change slide.
We're hoping Erin could help us with the sharing of the details, the patient case.
Yes, we can see Erin's slides. We see patient details slide.
Maybe
So,
Anita, can someone
yeah.
sign on to Zoom on their phone? And then you guys can read it from the phone?
Okay.
Sorry about that. Or someone,
Alternatively, you can open your own presentation off Zoom if you have it there just on your computer, and you can follow it, and we'll follow it on Zoom, and you can follow it on your computer if that's easier.
I can send it to Leah on her WhatsApp if you want.
Okay, Anita, are you still there? Do you hear us?
To access it from our phones.
Okay.
No.
So we can see the presentation. Erin shared the screen, and we have the slide that says patient details, age 11, gender female.
Yeah, we are sorry
Yeah.
for that. We're able to see now from our end.
Oh, good.
So the patient details, age is 11, gender is female. The diagnosis of the patient was disseminated KS, pulmonary KS, and oral KS, advanced HIV disease. Other diagnoses were left chest wound, post-intubation, and emphysema. So the treatment and significant investigations. For advanced HIV, the patient was on ABC-3TC-DTG and per oral Septrin at 480 milligrams OD. For disseminated KS, she completed 6 sessions of chemo. And for the chest wound, the patient was on IV metronidazole, IV fluoxetine, wound dressing. Other medications that were given were oral paracetamol for pain and fever. Investigations done, CD4 count was done on 30th of September 2023, and it was 140 copies. Skin biopsy was done on 6th of July 2023, and it was positive for KS. Full blood count was also done, WC 4.6, HB of 10, and also platelet counts of 187. Viral load was done on 14th of June. It was 225 copies. Another one was repeated on 21st of December 2023, and it was 128 copies per mil. CSF analysis was also done, and there was no malignancy. GeneXpert was negative. Holistic assessment, pain and symptom, including relevant treatment. There was pain on the post-chest tube site. The pain score was 2 out of 10, was put on oral paracetamol. And then there was also discharge from the wound where the chest tube was inserted. She was on daily dressing. The patient had restlessness and episodes of dyspnea. There was elevation of bed and also low dose morphine, and breathing exercise were taught to the patient. Continuation, holistic care, psychological concerns of the patient. There was grief, post-disclosure of the diagnosis. There was loneliness, being in adult ward alone. There was also dysfunctional family unit, was linked to orphanage post-discharge. Late disclosure of the status. Withdrawal and speaking to staff, was very sad looking after disclosure of the diagnosis of the serious illness. Disruption of school routine. She stopped her education due to her illness, and there was also abandonment by the immediate caretaker. Then family concern or family dynamics. The patient is a total orphan, fifth born in a family of 5. Both parents have died. Elder brother is unemployed. The second born and the third born dropped out of school, while the fourth born stayed with an aunt. She was abandoned in the ward during the last admission by the aunt. Effort to trace and bring them back to the facility were in vain. The patient does not have a social support system since the external relatives were willing to support only if they benefited from other actors. And the patient could not stay at home since getting food and basic need is a challenge, and the brother who was in school was the only one willing to take care of her, but at the moment it was not possible. Spiritual concerns, there were no significant concerns identified. Holistic assessment continuation, current collaborations and partnership in care. Tracing was done through the chief, the plan officer, and in charge of the area, but there was no solution. An MDT was formed. The case was discussed with the help of MSF, the hospital management, and the children department, and the child was successfully placed in an orphanage in Oyugis. Summary of the case: 11-year-old female patient, non-RVD patient since December 2022, with the previous history of PTB that was diagnosed on 13th of December 2022 and completed anti-TB treatment. History of KS, completed 6 sessions of chemo, has had 3 admissions since 2023 following the same diagnosis. Patient had also been diagnosed with emphysema. Chest tube was inserted and removed on October 2023. Currently, she's being managed for advanced HIV disease, disseminated KS, and wound on the left side of the chest was chest tube removal. Currently, on follow-up by MSF palliative team, post-discharge, post-disclosure, loss and grief counseling ongoing, and also staying in an orphanage in the US. So the key questions for the presentation: number 1, what could we have done differently? And then number 2, what did we do good, or the areas we can improve on? And then number 3, what areas can we improve on? Thank you.
Thank you, Anita. Thank you very much for sharing this case that was clearly, I imagine it was a very challenging case for you and the team to manage, given the bereavements along the way. Could I ask you, Anita, and the team that are there with you to reflect yourself as well on these questions? It seems you managed to me and to what you've shared the case very nicely. So can I ask you and the team to think about what you think, as you look back on the management of this child, what do you think went well? And what might you as a team, what is there anything that you as a team think you'd do differently if you had a similar case again? And then we can open it up to the wider group.
Anita, I don't know if Leah is there. Is she also able to speak? I know the social work team was involved in some support to her while she was still admitted.
Yeah, we are all here as a team, the social worker, the counselor, the nurse. And yeah, we have our supervisor here. So I think, first of all, what I would say that we did well was that at least we were able to link the girl to the orphanage. Number 2 thing, at least we helped the girl. She was going through a lot during the time that she lost the mother. So at least there was a team to support her. Another thing that we did well was that when the patient was in the ward, we were able to engage the girl fully until the time of discharge. Yes.
Thank you. Thanks for that. And I think, you know, the fact that you had access to chemotherapy for the Kaposi's sarcoma is really a positive, because in many settings, particularly where MSF work, there may well not be, for many patients, there is not access to treatment. to the chemotherapy treatment. So it's really good to know that you had access to that for your patients. Was that in collaboration with some partners? How did the chemotherapy? Did you refer to another centre that was able to provide the chemotherapy, or is that within the same hospital that you work?
No, we did not refer. We have the APCA clinic within the hospital supported by MSF.
Wonderful, wonderful. And then leading on to the second part of that, how have you as a team reflected on, because I understand this girl is still in the orphanage, is that right? She's still living there?
Yeah. Yes.
Yeah, yeah. Are you continuing to follow her as a team?
Yes. Yes.
Yeah.
The girl is still on follow-up by the social department and also the palliative care department.
Yeah.
Yeah.
Yeah, and have you had chance to reflect as a team, or perhaps that's what we're doing during this session now, about what if there's any part of her care that you might want some different views on from the faculty here, or from the participants that may have their own experience in different settings, or have you reflected on things that you think could have been done better or done differently whilst you were caring for this girl? And it could be in the area of symptom management, it could be in the area of providing the psychosocial support. So is there anything that you've learned as a team and that you would want to do differently if you were to have a very similar case again that you're managing as a team?
Yeah, we've reflected, and there's this area of art therapy, play therapy. So I think as a team, somehow we missed doing that, the art therapy.
And is that something you have access to? Do you have access to an art therapist?
At the moment, there was not access to art therapy for the girl. So there was not much to keep the girl active, something that could divert her mind from what was happening at the moment. And also 11-year-old girl, being in an adult world, the people around her were all adults. So I think that made the girl to be lonely and also to withdraw. She was just to herself. She had no age group people to link with, people to story with, apart from the healthcare personnel.
Thank you, thank you. And I think that's a good point to open it up to the group on, actually. So can others share about different ideas or different ways they've been able to engage a child who's facing a serious illness, particularly a child who may be quite withdrawn? This child was in an adult ward, so wasn't around other children that she might have been able to play with, but some different ideas of what might the team be able to do in a future situation if they have a similar case, how they might be able to engage a child of this age. Atieno, I hope I've got your name right. I think you're part of the Homabay team, aren't you? And please, if you've got a comment, please do share. Atieno, I see you've got your hand up, but your microphone's muted. There we are. Super. Go.
Okay, good evening. Just one point to get assistance is a part on exploring spiritual needs. I believe, but then we really need assistance on from those who have had experience with dealing with children on in palliative care, on how we can explore the spiritual needs, especially where there's withdrawal post counseling. Thank you.
Thank you. Thank you very much for that clarification. And can I just ask the faculty on the call if they could come back on that and just share different ways to provide spiritual support or different ways to engage the child who may be withdrawn with a serious illness? What ways have you used in the past that might be effective for a girl of this age or a different age even?
I know when we were, I was interacting with Leah around the time they were supporting this patient while she was still an inpatient. And I know oftentimes in our situations, we want an easy solution to make her happy, right? She was very withdrawn. She wasn't wanting to talk to anybody. And I think that is the burden that we carry when we agree to engage in palliative care. And I think, again, it's not easy. Very similar to the way Dr. Esther was talking about all the dilemmas we face with some of our patients and families. And this is a situation, I am not an orphan, so I also would not be able to personally understand what this little girl was going through. Yet I think in these kinds of situations where both her mother and her father had died, her main caregiver was not able to provide support for her, I think she needed somebody to attach to. So I do think that the team did an amazing job finding ways to really connect with her. I think the adult ward thing was very complicated because the way she could get really good care was through the MSF team, but again, it wasn't near any other children, so that was complex. But I think as you, as a team, were to assess, or if you have children like this in your wards, in other situations, I think if there is a team member that seems to connect, and you don't have to explain why they connect, they just connect well. If it's a housekeeper, if it's a lab technician, doesn't have to be the nurse. If there is an adult that is able to show a caring relationship to the child where their main caregivers are no longer able to do that for a variety of reasons, I think is really, really important. And then slowly developing that trust, because I think her ability to trust any sort of adult figure, it's all complicated for her now because her mother died and her main caregiver is no longer visiting her. So I don't think maybe at 11 she could explain that, but she's probably very sad too about all that is happening. So I think it is great to bring in art, especially in these kinds of situations. And you don't necessarily need beautiful paint, a piece of paper and some colored pencils, or crayons or something very simple. I know sometimes we don't even have access to that, but something where she could describe what she's feeling without saying it or even writing it. If she's able to write, then that would be okay. But I think that slowly each day offering these kinds of opportunities for her could slowly give her the ability. And again, that the connection with an adult, I think, especially in this situation, is really, really important. And it sounds like that's what the team did with the social work team and the palliative care team. So yeah, the spiritual domain for children, again, their spirituality is different than an adult spirituality, but I think again, it's not easy to talk with children about why did my mother die? Why am I so sick? Why am I in the hospital? Why is my family member not visiting me? But I think, again, not having the answers, allowing her to ask it, listening to her, being there, not walking away when she asks these difficult questions. It's not easy as a healthcare provider to listen to children talk like that, because I don't think we ever want children to be in these situations. But yeah, I think the consistency is really important.
Thanks, Erin. Some really, really useful points there. And can I just come back to the team in Homabay, and can you share about some of the points that Erin said? Was there someone in the team, as Erin sort of alluded to, that you were able to form a relationship with her, and was that something that was useful for this child?
Hello. I think we were able to form a relationship with the child because all this while she was in the ward, there was no support from home, but there was this brother who's willing to support, and he's still in school, so we could always connect the child with the brother. They could talk on phone, and she would be happy. Then this relationship, when the baby was always free with the team, so if she had anything, she had a problem, then if she sees one of the team members, then she could call you and maybe share it with you. So if it was a medical issue or maybe something that needs to be addressed, it was easy for us to do a follow-up because she already shared. So even now, if she comes to a follow-up, she's always free and you can see the smile on her face. She's happy when she interacts with the members of the team. So I think by her being open and sharing her problems to us means that she was comfortable and actually appreciated the help and the care we were offering to her. Thank you.
Thank you very much. So you had the brother you could connect with, and obviously the team, as you've described, were there for her throughout. And of course, she has to go through her period of bereavement, which will be, of course, ongoing. Dr. Esther, do you want to add something here?
Yes. In Kenyatta, we have a chaplaincy unit, and working with them, we actually found out that there are tools that are used to assess the spiritual need of patients. So I think it is important, maybe we could try to incorporate a chaplain in one of these sessions in future. I know Father Rick Bauer works a lot with children, and he might be willing to give us a talk on how to assess spirituality. We could look into some of the tools that can help us to identify the spiritual needs of children, and where possible, if there's a chaplain, we can have them as part of the team to help us address those spiritual issues. And again, where there's no chaplain, I think it would be good to have a chaplain on our team that we can be able to consult. So maybe we will have a discussion later with Erin and see how we can do that. Thank you.
Thanks, Dr. Esther, and thanks for the suggestion about having a session on spirituality in children, because that indeed will be probably learning for most of us on the call. So that's a very good idea. There's some other useful comments in the chat around play and returning to school as well. And do the team want to say anything about this child returning to school and what impact that had of being able to return to her studies when she was well enough?
The schools were opened on Monday this week. So she was supposed to be taken to school this week, and we had planned to do a follow-up about the same, maybe in 2 to 3 weeks' time after her joining school.
Okay, thank you very much. Thank you. Any other comments or ideas or sharing of similar experiences by any of the faculty members or any of the participants?
Hello, good afternoon.
Hello, Ali, good afternoon.
Fine, thank you. Good afternoon, good morning once again to all the team. Let me thank the presentations today. It was good, very nice presentation.
Ali, we've just lost your sound. Sorry to interrupt. We've lost your sound. Can you just check your microphone is still on?
Is it okay now?
Yeah.
No, we still don't hear you. We heard you at the very start, and then it cut out.
I can hear him, Catherine.
I can also hear him.
Now is it okay?
Yeah, it's okay. Yeah.
Thank you. I thank to the facilitators today, this evening.
No, it's still not. Is anyone else hearing Ali? Because I don't hear you.
I can get him quite clear.
Yeah, we can hear him, Catherine. I think your connection might have been slow. Sorry.
It's okay.
Yeah, I think go ahead.
I hope it was very nice today. I thank to my the facilitators and the team from MSF Homabay. Thanks to them. I would ask Anita one question about preparing the holistic assessment. I think that information and when they're doing the HIV testing, they receive they do the pre-test and the post-test counseling the time they are doing the HIV test.
Yeah, that's an interesting comment. I actually don't know how that all happened. Anita, are you able to share a little bit about how the HIV counseling happened with this little girl? I assume a lot of it happened while they were admitted. I know the mother and the daughter were admitted at the same time, and then the mother died. So when did any of that counseling happen? I don't know. It sounded like a very stressful situation, but it's a good point, Ali. Some of that counseling.
Okay, maybe I can respond. At the time of admission, the HIV status had already been known. So the issue we had was that the patient did not know about her HIV status.
Yeah.
So yeah, we began doing the partial disclosure in the wards, but the status had been known before.
To the mother?
Yes, to the mother. To the mother.
Not that it matters now, but do you know, like, was that a year before? Was it 6 months, just a few months? Had the mother been holding that?
It was a year before, but the mother had not disclosed the status to the child.
Yeah.
Yeah.
And then the mother consecutively got more and more sick and then had an infection and then she passed?
Yeah, true.
Yeah. Okay.
Yeah.
So it's a very good point, Ali. I think, again, there's a lot of systems in place, even in humanitarian settings, especially related to HIV and TB. And sometimes it seems like a lot for all these things, the pre and the post counseling, but any of those resources that you have access to, strongly encouraging patients and families to avail of those resources as much as they can, because we know that there's a lot that people have to process with a serious illness like HIV and advanced disease. So I think it's a good point. It sounds like in this situation, it was a complicated family, very sad situation, because it sounds like the father also had died years previous. So a lot of loss. So there probably were many reasons the mother didn't want to share with the daughter, but yeah. I think we are coming close to the end of our time. Catherine, are you good now? Is your connection okay?
I'm good now. Yeah, sorry,
Yeah,
sorry
okay.
for that earlier.
No problem.
Yeah, so just to ask the Homabay team, are you, I hope that discussion has been useful, and is there any final comments or any part that's you need clarification on, or any final points that you want to share as a team?
Can we do? So okay, at the moment the patient is still being followed up through the palliative care, the social work, and still coming at the post-discharge clinic for a follow-up. So we are still in contact with the patient. So what we do know more is from the team, from various people who have the experience with dealing with such cases, and the girls at puberty, pre-puberty, this age. What we can learn, any ideas, new practices, the good practices that we can learn from them, we'd appreciate.
So when you say any practices, do you mean beyond what we've discussed today? Are you looking for some different ideas, or are you talking about some tools that you can use, or just to understand a bit more your question?
Okay, about the tools, like for example, the tool for assessing the spiritual needs, and also if there are more ideas, if somebody has more different ideas, the people who are working with girls this age on palliative care and issue of HIV, all that combined together. If there's somebody with such experience, we appreciate to know so that we can learn how we can continue helping this child.
Dr. Esther, Dr. Zippy, can I ask either of you, is there anything else you can share, or any from your experiences of working in Kenya? I don't know if you also care for children or if it's primarily adults, but is there anything in addition that you're able to share with the Homabay team, or indeed any of the other faculty members on the call today from their experience?
Are you asking about if the existing tools or just experience sharing? Because we've shared a bit of our experience already and given our input, but I just wonder if you ask if some specific thing, because I think the team did the best that they could, and unfortunately we don't really have like existing standard operating SOPs or guidelines or something that are specific for children, and maybe that's something we need to look at. Dr. Nafula and team also are still young and vibrant. What can you do in terms of improving palliative care for children in this country?
Yeah.
Thanks, Dr. Zippy. Yep, go ahead, Erin.
Yeah, I just am wondering, so in this situation, even for the team, because it sounds like they're actually going to be her primary team ongoing with this, not only the emotional, but what would a child in her situation, what would her prognosis be? Is it, because it sounds like what, she had 3 admissions in 2023, that's quite a lot. Is it just based on how low her CD4 count is and the maintenance chemotherapy? Yeah, I do wonder. And we can definitely over the next month with the Homabay team connect them with some resources more related to like, will she live into her teenage life and her young adult life? It's way beyond my expertise, but I do think it would be good if we could help the team like prepare for what that does look like. I don't know. Catherine, are people's prognosis with KS okay?
So I just think this might be a good question to put. I've got limited experience with KS, and I just wonder if this might be a question that you as a team could put to the KS clinic.
Yeah.
So they will have a lot of experience caring for children with HIV and providing the chemotherapy, and they will know what her response to that has been. So it might be if it's a useful question as a team to know what her what the outlook is, and I'm sure it is for this girl, because there may be difficult as Erin alluded to, there may be difficult times ahead. So that might be a good question to go back to the KS team. And I think I'm sure the rest of the faculty will join me in saying that this is a very challenging case, and it sounds like you did a very good job of caring for her. And I get the sense that you are thinking that there's more you might have done. But the truth is, it's very, very difficult, to sit with this pain that the child has, and to sit with the difficult experience that she went through. And sometimes, we can't make it all better, and time does have to pass. And it sounds like, what the team have shared, what the faculty have shared, and the participants are, a lot of it are things you've already you've done. You've managed to sort of connect. You've kept her engaged with family. You were thinking about play. You were thinking about schools. So there's a lot of things you did, and I think you did very well. And hopefully, there's been a few things that the fact that we've shared during the call that's probably mostly just reassured you that you were on the right track, and you did the very best you could in what was a very difficult situation. And that would be sort of my summary for you. Please do jump in if anyone has anything else to add in, but it sounds like you did a very good job in a very difficult situation. In terms of tools, we can check in with Father Rick, who is a part of the PallCHASE team, and see if there are any tools particularly designed for children in spirituality. I'm not aware of any, but there may well be some, and we can share those. We can share those with the group if we get any answers back from Rick with some tools or some different advice from what's been shared already today. If there's no more comments, I'll hand over to you, Erin, to share about the recent workshop.
Yeah. I also do know Leah and I had been working on a book for children, and I know maybe we could get some support from the team in Eldoret, the Child Life team. When you don't have a lot of resources, a book that could be printed to help a child describe what their illness is, who they are, what it means to them. And I know that I had shared that with her. So I can also share that on the WhatsApp group later as a way to help children and families kind of describe what's happening from their perspective. And then that can be shared with the healthcare team. Okay, so we'll do this really quickly. Sarah Raynaud is also on the call with us now, and there was several of us that were at the conference that happened in November. So we just wanted to do a quick review of the conference in the next 5 minutes and ask you just a quick a request from our team. So we were several individuals that were in KEPCA, and I know a lot of you were on the call, who are on the call today were also at the conference that happened in Kisumu. And here is our beautiful team that helped facilitate our workshop. So from the right, Catherine, who's a palliative care nurse in Garissa. We have Annalise, Sarah, myself, Professor Julia, and Ali. We were all helping facilitate. We had a great turnout. We had over 100 individuals at the workshop. And during the workshop, Annalise and Ali had a chance to share about the background of what was happening in terms of palliative care in their setting in Dadaab. And it was great. They had a good opportunity to share about different patients as well as the actual systems that they work in. Both are not fully employed in palliative care. Both have other responsibilities, but do palliative care on top of their role. They do it very well, which is great. And then we went into some group work. So we had a chance to ask all the individuals that were at our workshop to think of some of the things that we had been thinking about in the previous year. And that resulted in us identifying some major topics. So it led us to think about coming together as a working group or a work group with two main focuses. The first one is going to be how to improve access to morphine in our setting. So this will be mainly focused on Dadaab, but I think a lot of the things that we will talk about during these meetings will be applicable in your setting if you're working in East Africa. So some of the things that came up from our meeting were to support potentially the registration of facilities, because when you are registered as a facility, you have access to morphine in Kenya. That is complicated in a humanitarian setting where some of the refugee camps operate outside of the Ministry of Health, but that was a strong recommendation. Also to improve education for morphine and training on how to safely use that, and also begin to incorporate some reporting tools. So if we can't report that we are using morphine, we may not be able to ask for it. So it's kind of what came first, the chicken or the egg, but these were some of the strong recommendations from the team. So Sarah, are you with us still? Maybe you can just unmute and wave to everyone.
Hello, hi, can you see me?
Yeah, perfect. Sarah is a palliative care nurse from Canada, and she has been supporting the ECHO training for the last year, and she was at the in-person workshop. So her and Annalise are going to take on this work group. We're going to do it a very short amount of time, just for the next 10 months. We want to have some, achievable goals. And we would be really interested if anyone on this ECHO call would be interested to join us. We don't need a big group. We can have, between 5 and 7 people on this group, but really people interested in improving access to morphine right in our setting right here. The next group is going to be referral pathways. So one of the things that we found in Dadaab is many of our patients with advanced illness don't have access to referrals. And a lot of that is outside of our control. Some of that is related to UNHCR and refugee rights in Kenya. But we would like to work together almost as an advocacy group, but also a work group. So that will be myself and Ali from PallCHASE. Again, the same amount of time, February to December, to just talk about this and identify if there's anybody that we haven't talked to or advocated with or connected with to better, formalize these referral pathways. So it could be related to transportation. It could be individual refugees with NHIF status. It could be a better liaison. I know with Catherine being in Garissa, our connection with the Garissa Cancer Center is better. But those are the few things that also came up from our workshop. So if you're interested in joining, I'll leave this on the screen for just a little bit, and I will put this link in the chat. But if you're interested in joining this work group, please join us. Sarah and Annalise, as well as myself and Ali, will be in touch with you in the next few weeks, because we would like to set, it won't be weekly meetings, maybe once a month or every 6 weeks. And we do have definitely an end date of December so that we can kind of report back to our community of practice about what we've been able to achieve. And the next one, this one is for the referral pathway. So if there is something that you are actually an expert in and we don't know you yet, or something that you're quite interested in, or something that really impacts your work and you would like to be more involved, please do get in touch with us. Yeah, Sarah and I are both based in Nairobi, and Annalise and Ali are both based in Dadaab. So we have a good connection. Again, for those working outside of Kenya, if you're still interested and it's okay for your time commitment, you're welcome to join, and we would love your input. And potentially we can also see if there's ways for us to support your work as well. And I think we're done. Sorry, that was a lot. I'll include the chats on the WhatsApp group. Our next meeting is going to be February 20th. So again, if you have any colleagues that want to join, it is an open community of practice, and we'd love for you to join us. If you'd like to present any cases, I think we have the next few months accounted for, but if you have a case like this one today, please do let us know. And we'll see you in about a month. Thanks, Catherine. Thanks, everyone. Thanks, Leah and team, Anita.
Thanks all.
Hi, team. See you.
Bye.
Bye.
Hello.
Bye, bye everyone.
Bye.
Bye.
Hey, I leave.
We can set it off now.
See, we leave first.
Yeah, you can.
Thanks, everyone. Good job, Homabay team.
Erin does.
Yeah. Nice work.
Hi,
You
Erin.
guys are. Oh, I should stop the recording.